Good morning, sir and madam. My name is Dr. Burra Vaskatejanya. I am a second year postgraduate. My guide is Dr. Lilia Professor, Professor and Head of the Department of Burns and Plastiquest Department. Here is a 3 years male child from Chennai, as given history by the mother. Deformed ear on the right side since birth, minimal hearing impairment since right ear, and there is no history of any difficulty in breathing, mouth opening, and feeding or ear discharge. Birth history: patient is a second child, born full term previous LSCS, so born from a non-consanguineous marriage. Antenatal history: the antenatal history, there is no history of any exposure to the radiation or any drug index or any fever. Developmental milestones are normal. Immunization is adequate. And as for the mother history, there is no any congenital anomalies noted by the mother. Past history: there is there is no history of any previous surgeries or any procedure done on the ear deformity. Family history: no history of any similar complaints with the parents, siblings, and relative. Vitals: temperature. Patient is thin-lipped and moderately nourished. General physical examination. Temperature is expected. Pulse is 94 per minute. BP is 112 to 68 right down. Respiratory is 40. Systemic examination: cardiovascular, respiratory, central nervous system, para-abdomen, non-particular test. On local examination, first I would like patient was examined in a well-ventilated room on taking consent from the mother and in sitting position, straight. Right ear, there is a remnant of auricle noted, as you can see. Helix, anti-helix, concha, tragus, antitragus, external aortic canal is absent. Low hairline is noted, and there are no any preauricular things. So on inspection, it looks like a tragus, and there is an obliterated external auditory canal. This is coming to the left ear. The patient is having a normal helix, but anti-helix is absent, as you can clearly see. Tragus, antitragus, scapha, and noted. No preauricular things. It looks like typically like a cupped ear. Coming to the facial examination, on orbit, both eyes appears to be symmetrical.
Can you sit a little carefully at the end?
Yes, sir.
Actually, the photograph is not appropriate. Be a little careful with these patients, because
Yes,
if you look at the... Just carry on, then I'll come back to that.
No, there is no.
The left lobe, you'll find a line through the inferior border of the right lobe is at a lower level because of the hypothesis. So if you pick that up, you get additional points. Carry on.
Even the nose, I don't think it is normal, but the nostrils are normal. We'll go on to the next photograph.
That photograph is more revealing. This one.
Yeah, this treatment is out.
Is it only isolated microtia or something else?
Something else associated.
Yeah, there is a facial.
You see what she said? She said that the alar bases on both sides are at different levels. So little points.
Right side, more of an hyperplasia. Mouth opening is adequate. Oral commission, it is a macrostomia noted on the right side, and upper lip, if you see, there is a mild hypoplasia on the right side. Lower lip, there is a mild hypoplasia on the right side. Oral cavity dentation is normal. There is no high arch or palate noted. Chin is deviated to the right side. As we can see, there is a loss of crowning on the right side also. Inability to close the right eye properly. That's the lower aspect of the photo. And there is a loss of labial fold on the right side, and deviation of the mouth to the side when smiling. Opposite side when there is a smile.
So when you have an inability to close the eye, just comment on the cornea at that point in the conjunctiva. You just want to know that there is no exposure. And you also would mention about the Bell's phenomenon, if it's there or not. Can you?
So hold on. What is Bell's phenomenon?
Sir,
Why did sir insist on this? Comment on conjunctiva, comment on cornea, comment on Bell's phenomena. There is significance. What is Bell's phenomenon? What is Bell's phenomenon?
It is related to eyeball.
Yeah, it is related to that. Yes. Inability to close the.
not
Anybody
able to
else?
close it.
Anybody else?
Anybody else? What's,
Rolling
can one person clearly tell us?
Which way it rolls?
So now, attempting to close the eyes, there should be uprolling of the eyeballs. We check this in order to prove that there is no corneal exposure.
So that protects the cornea.
Yeah, it's a protective reflex.
When the patient sleeps during the night, for 8 hours or 9 hours when the child is sleeping, is the cornea line exposed or not? So that's what the sir insisted that you should comment on that. You should ask mother. Right?
Patient inspectory findings are confirmed. Muscles and mastications are normal. On bilateral temporal mandibular joint is normal. Superficial temporal artery is felt on bilateral side, and there is no evidence of any cleft or cleft palate. In inspection region, I would like to examine the normal chest region of the patient, which is normal in shape.
Just one, how do you examine the temporomandibular joint? What did you do to clinically examine the temporomandibular joint?
So we will keep the both the thumb and the index finger in the external auditory canal. Like thumb is in the external auditory canal and the index finger on the
The thumb won't go.
little finger.
No, you should be sure. You are putting your thumbs in the external auditory canal of the boy or a girl.
Little finger.
No, you can't say. There are 5 choices. You can't say, sir, if thumb is not accepted, I'll put my little finger. And if we say no, not little, then you'll say index. Did you do that? Have you seen anybody doing it? Patient is sitting in front of you, can you imagine? How do you put the thumb like this? So, or you stand behind the patient. Where? What is the correct position?
In front of the patient, I would keep the index finger or the little finger in the external auditory canal.
And
On the temporal mandibular joint, I would like to keep the thumb and ask the patient to do it.
how will the patient listen to your instructions? You've already blocked both the. So you need to tell patient first कि मैं आपके कान में उंगली डालूंगा. I'm speaking Hindi. You understand?
हाँ सर.
You understand Hindi ना? पहले बताना है उसको. You need to tell.
मम्मी को explain
और
करना
फिर
है.
आपने मुंह खोलना है. करके दिखाइए बेटा ये मैं डाल. That's what we want. Alright?
Why is it important here?
Why is it important?
Sir, there is a chance of the patient is having the hypoplasia of the mandibular region. So whether as the patient grows up, the patient may develop the
Anyone who wants to?
cephalo.
What is important? So, what is your diagnosis?
Patient is my diagnosis is right-sided cranial-facial microsomia, non-syndromic. The right ear, according to the Tanzas classification, it is type 1 anoxia with facial palsy and low hairline. Left ear, according to the Tanzas classification, it is type 4 ear.
So, what is the classification of microsomal syndrome?
What do you mean by non-syndrome?
There are no typical features in as we see in Recessive syndrome or
Of the eye, you have got the nausea there, you have got the external auditory canal absence. There are facial deformities. What more you want in syndrome?
Any other syndrome will know?
golden man syndrome.
What other features are not there in this for the syndrome?
Patient is not epibulbar dermoids and low anti-Mongolian stand difficult. And there is no lower eyelid down slanting of the lower eyelids as is typically seen in the Treacherkolin syndrome.
All features must be included.
There will be few hallmark features that has to be seen.
For
Except
example,
is a syndrome. Craniofacial microsomia itself is a syndrome. You don't, with that name you can't say it is not syndrome. What is syndrome?
in
Typical
general,
features.
in general, what is a syndrome?
Definition of syndrome.
Do you call isolated cleft lip a syndrome?
Multiple factors involving
Factors for
Multiple.
clinical features involved. Multiple parts or multiple things involved.
In the exams, this is how you will get stuck if you don't give a correct answer. And if you add non-necessary terms and then they will ask you questions about it and then you will forget the main frame and you will go into a deeper burrow and you will get stuck. So when you are answering, you should know what questions you can expect from every word that you are presenting,
Yes.
and then you should be prepared for that. Otherwise, don't talk about this. That's how you can get dragged away from the mainstream.
Especially MCH exam.
That's
Those are super special
You
exam.
don't know the answer, better to say, sorry, I don't know. Go ahead. Because if you try to manipulate your answer here and there, you are stuck more.
Or you should drag the examiner to where you know very well.
Yeah. What you say
Otherwise,
is right. You guide the
otherwise you
examiner.
should
What
drag the
you want to
examiner to
answer.
where you know everything about it. Otherwise, don't get stuck with words that you can't answer.
Okay.
So syndrome is a set of clinical features, signs and symptoms, which occurs frequently with the same pattern. That is an established syndrome. So craniofacial microsomia, you have got set of 12 features, out of which you have got 8 features here in this. So it will consistently occur in the same pattern because of the developmental pattern which occurs. So that is known as syndrome when you have got set of clinical features. So you have to delete that non-syndromic part because this is syndrome by itself which justifies. Go ahead.
Your examination is complete. You have come to diagnosis. That means your examination part is complete. You have missed. Or you would have lied. You have not seen the patient. You have got the slides only, right?
This is our patient.
This is your patient? All right. Then
What was macrostomia?
you said, yeah, macrostomia you said there is mandibular hypoplasia. So how do you quantify it? How much? Do you draw some lines? Do you do some measurements? That would have become a good impression.
And the measurements from the lateral commission to the lateral canthus of eye to the tragus as well as from the lateral commission to the lobule, and then from
There is no
the
trackers. There is not. The lobule is also doubtful.
When
then from the
no, answer that question first. Don't jump on to the next question. Answer that question first. There is no landmark here. You have to go straight.
after palpation of the superficial temporal artery of then
That is a vertical end. Where is the normal?
Mandible कैसे नापा आपने? How did you measure the mandible? You said this is right side is shorter. This is longer. Or
You can say that.
did you say that?
It is
No, no, it is.
areas and say.
It is he said it's smaller.
inspection features.
He didn't say that.
Mandibular hypoplasia कहाँ है?
अभी तक तुम्हारे को results की classification तक आया नहीं है।
तो वो diagnosis पे आ गए ना? He has come to diagnosis. That
और
means
उसके बाद फिर investigation में
that
आया।
means many. I thought probably you got only slides. You didn't see the patient.
He has seen the patient.
He has seen the patient. Then you should have drawn some lines. You should have told us that I would have liked to measure this distance, come right side, left side. You said right macrostomia. पता होना चाहिए. Exam में should that you know all this.
Let us figure out the time
And
also.
because you've already, now you know it's a syndromic, so in general physical examination, do you like to look for anything else?
Like I would like to see any vertebral or anything or any just like any exhibition, lateral limb anomalies, renal anomalies, thoracic. I would like to rule out all those anomalies and then
Okay, that's
Okay.
One
Go
more
ahead,
thing.
please.
When you're doing that examination, you also have to plan your treatment. It's a 3-year-old child, right?
Yes, sir, that is.
So here may not be relevant, but if it's an older child, there's something else. Say it's a 10-year-old child. What else would you examine in this as part of your treatment?
Then I would like to examine the ear examination completely, and as well as audiometry I would like to do. And I would like to do a chest X-ray, as well as I would like to do a CT scan of the temporal bone, especially. I would like to work up for the anesthesia for the surgical workflow.
What investigations?
So as the patient is over 3 years, still I would like to wait till the patient goes till the 10 years, and then I would like to
You will not do any investigation.
so that I would like to take a X-ray of the skull to see any
Chalo for examination.
It is up to 10 years.
8 preschool stage.
Preschool.
Preschool?
Nowadays people are
Ten
going
years
to college.
preschool, 10 years
School
okay,
जाना है।
10 years preschool.
What is the definition of preschool now? They know the definition of preschool.
So you never know.
लोग बाइक में और आकाश में
Something
करा
else,
देते हैं 5 साल
something else is there, not the preschool.
IIT
Okay, preschool.
5-year-old child IIT coaching.
No, so what's
So
the
I would like
idea?
to wait till the age of 6 years for the chest X-ray.
अरे लेकिन बाकी सब चीजें other things are.
10 is also, you do it too early, absorption होता है, so 10 now it is accepted that 10. So your earlier books will write 6 to 7 years of age. Now it's accepted to
Where
do that
6
age
to
of
7
10,
years
because
of
otherwise
age?
the cartilage gets absorbed.
6 to 7 years of age क्यों? उसके पहले की? या डॉक्टर साहब कैसे बता रहे हैं? Up to 10 years it's okay. हाँ?
Chest circumference.
So why?
Cartilage paper बनाते हैं
चलो
The doctor reason?
नहीं
Second?
और ये adult size आने के लिए.
How much of the other size?
ये adult size आने के
By the
लिए
age of 4 years, it attains at the 85%. By the age of 10 years, it completely attains the adult size.
first line you have spoken with confidence.
ऐसे ही
See, all of us
बोला
are
ऐसे ही
happy.
That
All of us are happy.
that I wanted to know.
Speak with
This is
confidence.
sentence. Not preschool
So
or.
let us restrict our questions to only Anosha part.
Anosha,
There are
yes.
many other things.
Yes.
It will vary.
Okay.
Carry on. Carry
So
on.
how?
Carry on. What will you do?
I would like to do the management. I would discuss problems are on the right side, and mainly the lower waveline is noted. So first I would like to reach the lower waveline. Then the right side here, I would like to reconstruct. I would like to do the autogenic reconstruction.
Autogenic. Say that again. Autogenic reconstruction. Don't say autogenic.
Autogenic or
Yes.
Autogenic.
Okay. Which technique?
I would like to do Nagata technique for this patient.
Why did you choose Nagata? Are there any other techniques?
There is other technique called as bread technique.
And one is prayer, one is Nagata, and
Permits.
That's correct. Okay, 3 are enough. So why did you choose Nagata? Not prayer or prayer?
In this case, I would like to wait for till the age of 8 to 10 years so that the chest circumference. And I would like to plan in a 2-stage manner. And the first stage, I would like to take the auricular framework and then wait for 6 months and then do the second stage for the elevation and the framework.
What are the differences between Brent and Nagata?
Brand technique is a 4-stage technique and the Nagata is a 2-stage technique. The age started in the Brent is around 6 years, 6 to 8 years, whereas in the Nagata it is 8 to 10 years. And in Nagata, in Brent there is no need for chest circumferences as a reference point, whereas in Nagata it is minimum chest circumference is 60 centimeters around. In this case, the first stage involves the elevation of the creation of the auricular framework cartilage, and then second stage in Brent is rotation of the malposition lobule. And
Telling Brent or Navata?
Brent.
Brent, first stage is?
First stage is creation of the auricular cartilage. Second stage is the rotation of the malposition of the lobule.
That
Third
don't say
stage,
creation. It's framework fabrication. Little bit words here and there, it gives better impression. Framework fabrication.
framework fabrication.
That is done. And
Second stage is
now first to complete, it's fabricated, it's still on table. Then you have to implant it. Creation of the pocket. So you have to tell all these things and create the pocket and harvest the battery, framework fabrication and implantation.
the second stage is the rotation of the malposition lobule. Third stage is the elevation and creation of the retroauricular sulcus. Fourth stage will be the deepening of the concha and creation of the tragus. This is in Brent. Whereas in Nagata it is only two stages. Stage 1, 2, 4 of Brent is stage 1. That is framework creation, pocket creation, and placement, and rotation of the malposition, and deepening of the concha as well as creation of the tragus. This is stage 1. In stage 2 again it is the elevation and creation of the retroauricular sulcus, which is covered by the flap, temporoparietal.
It's covered by?
Temporoparietal fascia flap.
Temperature facial.
After that it is covered with ultra delicate skin thickness. Scrap.
What is that? Ultra delicate?
Thin or
Ultra delicate.
It's a word fusion.
Chalo, we know that you're going to treat that skin with respect.
Yeah, you're going to describe that skin.
Delicate.
Ultra delicate, thin skin.
Skin.
Is it written?
What is this type of skin?
See, examiners, what I told you, examiners will catch.
Split skin graft.
As it is, you would be under stress when you are appearing in your final practical examination. And you would be facing, a student would be facing 4 examiners. There are like 4 examiners. They'll catch each word. Alright? So don't use this ultra fancy words. No problem. No problem. Okay. 5 more minutes? Okay. Now it is the harvest extra pericontinent or subpericontinent?
It is extra pericontinal in
Yes, you missed that point. That's the difference. There's 50% possibility of being correct.
Brent is extra. This is subpericontinal. Extra pericontinal is Nagata. And it is a pericontinal.
Why is it?
Because it is taken in the earlier age as well as when compared to the Nagata.
And what does one become? The one who is harvesting subpericontinal. What does it become?
That
The
pericontinum has to be left.
the pieces of the leftover cartilage. What do you do?
During the
Put them
second
in
stage
the put them back.
Can be used in the second stage for the knee.
No.
What do you do?
Listen to
Kept
me.
back into the
What
chest
is,
region, same.
what is-
Okay, exactly.
what is the idea of doing that, and what does he do? You take the pieces of the leftover cartilage and you leave it where?
Chest region only.
Where? What do
Chest
you do
region
before you
fixer.
do?
Chest is too big. Chest region, exactly.
Most of all,
What is he trying to do by that?
by
He says that it,
pieces.
the remaining small pieces of the carved cartilage are put back into something on the chest
So that
so that something else happens.
something else happens.
So he has to put it into a, so therefore it means that he leaves the pericardium there.
It's subpericondyal harvest. So you put those pieces inside and then close it.
And the idea being that
It regenerates.
it will regenerate.
And brain technique में what do they say?
Brent anterior pericontinum
Little pieces that are left over, what will you do with
What do
them?
you do with that?
framework.
Little pieces.
All that, some are little, some are bigger also. What do you do with them if you're doing the Brent's technique? Basically, in neither of them are we binning it. This is for sure. But in the Brent's technique, we do something specific.
So this is one of the important differences. You should read all this. Now will you harvest it from the right side, left side?
Left side.
What techniques?
Right side is the lateral.
I was asking the differences, the basics. These are some basic differences. Okay?
How do you locate the position of the, you know, if you go back to the picture?
We must have planned. Have you planned this?
Yes.
Go ahead next.
Oh, go to your, yeah.
So I would like to make a opposite ear dimensions and make a framework on the X-ray, and then I will give it a opposite side based on the lateral canvas. There are two horizontal lines and there are two vertical lines. The horizontal line first one indicates the line drawn from here.
None of them is horizontal, none of them is vertical. Out of these four, they are all straight lines, but they are not horizontal or vertical.
So the vertical or the oblique line that you have,
The
what
dorsal
is that?
the axis of the dorsal of the nose closing and the axis of the ear, but they are not parallel to each other. They have an inclination of
Okay.
15 degrees.
So you want them to be parallel. So these lines,
They're parallel, no? Why is it not parallel?
no, he says there's a slight, there is a very slight. So if you go back to Ocker, he's got a very simple way of putting the location and to check that you've got the right location. You take a transparency, you mark the midline, you mark the eyebrow on it, and you mark the left ear on it. And if you just flip that over, you'll very easily see where it should be located. Because here, what's happening on the right side is the ear is also, the tragus, if that's the tragus, is at a much lower level compared to the opposite tragus. So be careful about where you place your ear. So the position of where you put your ear is critical over there.
Why is that at a lower level on this side? Last question. Why is it at a lower level?
So there's no ear. There are no other parts of the
Can be higher level. Why is it lower? Usually Microtia are lower level. Like hairline is lower, ear is lower.
Is there any embryological basis to this?
because of the CPD blockage.
No, no.
What's the development?
Superficial development. 5 weeks at the age of
Yeah.
5 weeks. It is ear is formed from the first and second brachial arches.
Yes. So brachial arches are found where?
Thank you.
Cervical.
Sorry,
So
thank you.
they ascend.
Yeah.
They are not ascended. That's the reason. I think so. Professor. Thank you.
So you must know the development of
Yes, that actually the first child, sir. Because he's also having a
Brother of the
first child.
The siblings both are.
Right.
So it is a familial.
That child is also not having a
Left side?
it is also like typically looks like a cup here.
No, he's got everything. Look carefully at it. He's got everything.
helix is there.
You said in previous slide, you said anti-helix steps. There is anti-helix and this. Go, come from this side.
Yes, sir.
कोई लगाओ ना
अरे patient.
ये go there. Tell me the parts.
Root of the helix है helical ring है sir. ये this is anti helix sir. This is crus and inferior crus sir. Triangular fossa.
Yes.
Tragus sir.
Yes.
Anti-tragus sir. Lobule there.
Between tragus and anti-tragus.
This is the cavum.
No, between tragus and anti-tragus. Along
There is
that
intertragal.
Intertragal non-knowledge. And then this is the concha cavum sir. This is concha sir. And triangular fossa.
No, you are saying two parts of concha.
Yes sir.
There are two parts.
Simba concha and cavum concha.
Yes, correct.
Simba concha is this one, cavum concha is this one.
Correct. And one is left. That is scapha.
Scapha.
Where is scapha? That is scapha.
This is the
Only one is left. Put your finger on what part is left. That is
On the scaffold.
This is what happens in
You told that.
Sir, okay.
Okay, good.